The World Health Organization classifies the combination hormonal birth control pill as a group 1 carcinogen. It's the same category as tobacco and asbestos. Infertility is not a disease. It's actually a symptom of other underlying diseases. I believe that women should be able to make an informed choice. And to do that, we need to give them information about how medications work. I have an opportunity to teach medical students about natural methods of family planning, and the students' response was so overwhelmingly positive.
Pharmaceutical companies, the IVF industry, big lobby,
Yes.
Lots of money. What you're doing is let's actually care for the patient.
Yes.
And so there's not this billion-dollar pharmaceutical company. Hey, everybody. Welcome back to the Lila Rose Show. I'm super pumped today to have Dr. Marguerite Duane in the studio today. Dr. Duane is the founder of FACS, which is an incredible organization focused on fertility awareness. She is a board certified physician as well as an adjunct professor over at Georgetown. She has many accolades, but most of all, she's someone who's incredibly passionate and knowledgeable about women's health. And we're going to be deep diving the topics of hormones, health, and fertility. We're going to talk about miscarriage and how miscarriage actually can be prevented in many cases. Most people don't know this. We're going to discuss birth control and some of the truths about the birth control pill that, again, not a lot of people realize. She also shares the incredible fertility awareness-based methods that can empower women to truly understand and appreciate their bodies and seek optimal health. This episode isn't just for women, it's for men too, because this is important for any man who is a husband, a father, who hopes to be a husband and a father one day, or who just wants to understand women more. Obviously, it's focused on women's health, but anything with regard to fertility or miscarriage also absolutely involves men. And we've got a special bonus segment over at rosereport.supercast.com for Rose Report members, where we have a whole special segment with Dr. Duane spinning the wheel, answering questions. You're going to enjoy it. Go check that out at rosereport.supercast.com. Dr. Marguerite Duane, thanks so much for joining the podcast.
Thanks so much for having me.
We're really lucky to have you out here. I knew you came a long way and you're a very busy lady, so thank you.
You're welcome. I'm glad to have the opportunity to share with you.
Now, you're one of our OG podcast guests. So back in the day when this show was just an audio show and we did like 25 episodes during the pandemic, way back 5-6 years ago, you were one of our most popular. People loved your episode.
Oh, that's fantastic.
So I've been wanting to have you in studio to do a proper in-person audio and video episode because what you do is so transformative. I think it's made an incredible difference. You starting FACS. We're going to learn more about your organization, your work as a physician. And it's just incredibly important. So thank you so much for making it out here.
You're welcome. Thank you.
I'd love for folks who are not aware yet of what you do. Tell us a little bit about FACS, your organization.
Sure. So again, I'm a board certified family physician and co-founder and executive director of FACS, which we started in 2010. I co-founded the organization with another family physician, Dr. Bob Motley. And originally FACS stood for the Fertility Appreciation Collaborative to Teach the Science. And I think our name so beautifully explains what we do. We're all about focusing on the gift of fertility. And to appreciate one's fertility, you need to understand it. And you can learn to understand your fertility and the female cycle through tracking. We're collaborative in that we work with all of the methods. We work with medical professionals from all specialties, whether OBGYNs, family doctors, naturopaths, nutritionists, anyone in the healthcare space that really cares about empowering women to care for their reproductive health. And finally, we focus on teaching the science. We're really focused on promoting the latest evidence and sharing the most up-to-date science underlying how the female cycle really serves as a fifth vital sign, how women can learn to chart their cycle, and how we can use this information to diagnose, monitor, and manage a wide range, not only of women's health conditions, but also for couples who are dealing with infertility. So FACS, the Fertility Appreciation Collaborative to Teach the Science. Again, we started it in 2010, but in 2022, we became our own nonprofit, officially known as FACS About Fertility.
So what got you so interested in, fertility awareness might be a term we could use, restorative reproductive medicine. I know these different terms to describe, but it's basically seeing a woman's fertility as a good thing, first of all, and understanding how it works at the bare minimum. What got you into that?
Well, I think it stems back to what brought me to medicine. And for me, my vocation to be a doctor, I knew I was called to medicine on November 2nd, 1979. And I can say that with such specificity because that was the day that I watched my baby sister being born at home.
Wow.
And that was an unbelievable
How old were
experience.
You?
I was just 8 years old.
Wow.
And I sat next to my 9-year-old sister at my mother's feet and we watched our baby sister being born. And I was like, this is the most amazing thing ever. This is what I want to do when I grow up? And at the time, I didn't know what kind of doctor I wanted to be, but I pretty soon decided I wanted to be a family doctor. I loved caring for women, but I loved caring for children, men, grandparents. So I pursued my passion for medicine, went to college. I actually did a master's degree in health administration before going into medicine, and pursued family medicine. And again, really passionate about women's health, wanted to deliver babies and take care of moms and babies. And it was when I was on OB call one night as a first-year family medicine residency at Lancaster General Hospital in Lancaster, Pennsylvania, where I happened to be on call with a senior resident who was trained in one of the methods. Her name is Dr. Pearl Huang, and she was trained in the Creighton model. And as I was sitting there on OB call, doing what any good intern did on OB call, writing birth control prescriptions for all of our postpartum patients, Dr. Huang decided to talk to me about how birth control methods work, the potential side effects and impacts on breastfeeding, postpartum bleeding. And she talked to me about the fact, there are some methods of family planning that women can use that don't actually interfere with her cycle and have no medical side effects. And I thought, what are you talking about? Every form of family planning has side effects, whether it's an increased risk of depression due to the pill, abnormal uterine bleeding with IUDs, even condoms can cause local sensitivity reactions. And she said, no, women can learn to chart their cycle, signs of their cycle, to know where they are and when they may be fertile or not, and use that information so they don't have to do anything to disrupt their cycle. And I thought to myself, how have I never learned this? I'm a doctor. I'm passionate about women's health. I'm a woman. When I was in college, like most college students who went to student health with like a reproductive health concern, the only option that was offered to me was birth control. And I thought to myself, why didn't I know this? So that night on call was as transformative for me as seeing the birth of my baby sister. And that really sparked my interest in learning more about women's reproductive health and how we can teach women to chart their cycle to better monitor and manage their health. And that was back in 2000. Flash forward a decade later, I was on faculty at Georgetown University. I was the medical director of 2 community health centers in DC, caring for a largely underserved minority population. I was married with 2 young children of my own when one of my colleagues at Georgetown said, we're looking for faculty to volunteer to teach courses to medical students on topics that will make them more well-rounded as physicians. And I thought to myself, this would be an incredible opportunity to teach even a small group of medical students about natural or fertility awareness-based methods, because I didn't learn about this as a medical student. And I thought this would be a great opportunity. But the rational part of my brain kicked in. I thought, well, I'm working full-time as a medical director. I have 2 small children. Like, with what time? But I really felt convicted that I needed to take this opportunity to teach these medical students. And so I reached out to colleagues in the field and said, hey, I have an opportunity to teach medical students about natural methods of family planning and restorative reproductive medicine. And my colleagues were like, this is great. We should do this. So in the end, I had 9 students take the class, which was great because they limited it to 5 to 10. And I had 12 people teaching the course. And not just anybody. Like, I had Dr. Hannah Klaus, who worked with John and Evelyn Billings and created the Teen Star program. I had Dr. Richard Faring, who developed the Marquette method, fly in from Wisconsin to give an hour lecture on the Marquette method. And the students' response was so overwhelmingly positive. This is the most clinically relevant information I've learned. Why isn't this a part of our basic reproductive physiology class that we take? And one student said, this is something every medical student should learn. And I thought, you're right. This is something every medical student and nursing student and any health care professional who cares for women should learn. So that is what motivated me to connect with my colleague, Dr. Bob Motley, to start FACS in 2010.
As you know, Mother's Day is around the corner, and I love finding the most thoughtful gifts for my mom, who deserves the world and more, for her special day. Cozy Earth has got your mom covered. Their ultra-soft, breathable bamboo bedding and pajamas are the perfect gift, comfort that feels like home. I personally love my Cozy Earth bamboo pajamas. They're incredibly soft, they keep me cool at night, and they're high quality so I can wear them again and again. And right now, Cozy Earth is offering something very special. From May 2nd 2nd through May 4th, you can buy one, get one free on their bamboo pajamas with my code Lila, BOGO. Go to cozyearth.com and use the code Lila, BOGO to get pajamas. Buy one, get one free. Or to enjoy their sheets, robes, loungewear, or any other product, go to cozyearth.com, and anytime you can take 40% off your order using the code Lila. It's amazing, Dr. Duane, because you are a pioneer. I mean, I would maybe say you're the pioneer, because I remember the space, and I'm in a space where I know what's on the table in terms of, fertility awareness-based methods, et cetera. But I remember being at college, in college in I graduated 2010. So those years. And I just remember the conversation among my cohort, other young women, secular women, not necessarily a faith background, just everyday women, right? And they're all on birth control pills. I was one of the rare ones that wasn't. And it was a no-brainer. It was like, this is what I've been on since I was 12.
Right.
I think a decade plus later, a decade and a half now later, the conversation even culturally is very different on birth control as this sort of, response to any issue that a woman may face, including as a contraceptive. And now there's all of this more opportunity, quite frankly, for the information that you've known now for decades to finally create some sort of traction in a mainstream way. So I would say your work doing that has been absolutely essential. You truly are the pioneer. You threw out a lot of names like the Billings method, I think the Creighton method. So there's a lot to get into here about what these fertility awareness-based methods even are. Super excited because you are the expert. I do want to just talk about the landscape for a minute. I've noticed, again, more people being opposed to the harms of birth control, even being aware of them. I've also noticed more of an appreciation for what fertility is. And you mentioned it as the fifth vital sign, I think was the words that you used. I'd love you to share more about the kind of, as you see it, the landscape over the last decade in terms of how our healthcare system approaches a woman's fertility, her periods, any reproductive based issues. And if you think that they're, where the deficiencies are.
Yeah, let's talk about the landscape of women's health. So when I was training as a medical student in the late 90s and as a resident in the early 2000s, the way that we were trained to approach women's health is that the pill is the panacea for all that ails women. So if a woman would come into the office with irregular cycles, put her on the birth control pill to quote unquote regulate her period. In fact, it doesn't regulate her period. It gives her a regular withdrawal bleed, but it doesn't get at why is she having an irregular cycle? Could it be polycystic ovarian syndrome, one of the leading causes? Maybe it's functional hypothalamic amenorrhea due to stress or overexercise. Other conditions, painful periods. Again, a very common complaint that young girls go to the doctor with. And again, the way we're trained to treat them is like we put them on the birth control pill. Well, that's how I learned how to practice initially. And what I discovered is that what the pill does is it suppresses the woman's hormones. It suppresses her cycle. So while it may alleviate the symptoms of pain or give the appearance of giving a woman a regular cycle, it doesn't actually get at the root cause and help us to make the diagnosis and really treat the underlying condition. And so over time, not to mention all of the side effects associated with hormonal birth control. As I mentioned, there's been large studies in Europe showing hormonal birth control has statistically significant increased risks of depression and suicide in adolescents. The World Health Organization classifies the combination hormonal birth control pill as a group 1 carcinogen because of the increased risk of breast, cervical, and liver cancer. It's the same category as tobacco and asbestos in terms of increased cancer risk. I believe that women should be able to make an informed choice. And to do that, we need to give them information about how medications work, how pharmaceutical agents work, and how they may or may not actually treat the underlying symptoms. So, for example, with painful periods, one of the most common causes of painful periods is a condition called endometriosis. Endometriosis is a condition where the cells that line the uterus grow outside of the uterus, right? So if you think about cells that grow where they're not supposed to, I would ask your audience, what do you think of? What condition comes to mind when you're thinking about cells that grow where they're not supposed to?
Cancer.
Cancer. Exactly. So to be clear, endometriosis is not cancer, but it behaves like cancer, right? And we don't treat cancer just by taking out a part of it or by suppressing the symptoms. We go in and try to remove it all. And physicians like NAPR-trained surgeons or minimally invasively gynecologically trained surgeons who are trained to remove endometriosis in its entirety can significantly improve a woman's overall quality of life and her fertility. But the way we're trained in medicine is we put women on the birth control pill. Again, that may suppress the symptoms, but the condition will continue to spread. So in the United States of America, which arguably has one of the best healthcare systems, the average time it takes from the onset of symptoms of painful periods to the diagnosis of endometriosis is to 10 to 12 years.
They just
over
didn't
a
know.
decade. They just didn't know.
The woman they have endometriosis
Lila,
for a decade and they never got it properly
I
diagnosed.
have a patient right now who at 15 went to her doctor with painful periods, was put on birth control pill for 20 years, still suffering from pain, actually had back surgery because she thought it was related to a back condition. No issues there. Finally went off the pill at 35 because she wanted to have a baby and was told, you have to do IVF. You have endometriosis. There's no possibility you're going to be able to conceive. She didn't feel like she had another option, pursued IVF, gratefully was able to have one child, but lost 2 embryos in the process, came to me at 40 and was like, I want another child. And all they're telling me is I need to do more IVF. I said, no, you need to have surgery and have your condition treated. Lila, from the day I saw her to the day I got her in to see an endo specialist, Dr. Patrick Young, one of the outstanding surgeons in the country, she had surgery, and then within a month, she was pregnant.
No way.
At the age of 40.
So what were you operating on? When you're treating endometriosis, I'm sure there's lots of different treatments, but one of them you mentioned is surgery.
So surgery
what are they doing?
Is the treatment.
It is the treatment.
It is the treatment. Endometriosis. So as a family physician, I cannot diagnose or treat endometriosis. I can raise the level of suspicion and say, this is likely endometriosis and we need to have you see a surgeon. So they go in and they remove all of the endometrial implants, which significantly reduces the inflammation and creates a more favorable environment. So
for implantation.
For conception and implantation, which is so critically important. So again, 4 years going down the IVF route to have 1 child and 2 losses, 4 months working with myself and Dr. Young to be able to conceive naturally.
Amazing.
So it is possible. Now, I wish I could say to every patient, yes, this can happen, but there's so much we can do when we apply the principles of restorative reproductive medicine. We look for the root cause of the underlying conditions of infertility, of painful periods, of irregular cycles, and we diagnose and treat the underlying issues rather than this Band-Aid approach, suppressing symptoms with birth control, circumventing the underlying cause of infertility with IVF. No, we need to make the diagnosis, identify the root causes, and treat them to help women and men live their healthiest lives and optimize their chances for having the family that they so desire.
Why do you think there's such a knee-jerk reaction to so many conditions? Cystic acne. I know some of my girlfriends in college, it was like, you're on the birth control pill because I got on it at 13 for cystic acne, or obviously painful periods, which might be actually endometriosis, which is then going to go untreated when the birth control is masking that. But why I don't know if you have a theory on this, but the medical establishment up until even just the last few years, it's kind of changing now, but has been so monolith in its just using, again, the magic pill, the birth control pill as this panacea treatment. Why do you think this is?
Well, this is what we learn in medical school, right? And for better or for worse, the pharmaceutical industry has tremendous influence over what we learn in medical education.
They make money with every prescription. With every prescription.
The birth control industry is a multi-billion-dollar industry because women are prescribed birth control for way more than just birth control. So it has a huge influence. It's what we learn in medical school. And until we started teaching the FACS elective at Georgetown in 2010, this was not covered in mainstream medical education. 2018, we were able to get our elective officially approved as an away elective. So we could then start teaching medical students, not just at Georgetown, but at medical schools all over the country. So since the last time I've been on this podcast in the last decade, we have now taught over 1,000 medical students from over 100 different medical schools about fertility awareness-based methods, their role as the 5th vital sign, which it's not me saying that, it's the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics that recognize the ovarian menstrual cycle as a 5th vital sign. So at FACS, we're teaching medical students to do it, but it's still not a part of mainstream education. That is until this year. And I don't even know if I'd shared this with you, but last year in the summer of 2020, 2004, I took a new position at Duquesne University. They opened a new College of Osteopathic Medicine. And when they opened the college, they launched a Center for Fertility Awareness Education and Research. They hired me as the first director so that we could integrate this education at every level of the medical school curriculum. So in November of 2024, I had the opportunity to spend an entire day teaching all of the medical students about natural or fertility awareness-based methods and their role in women's health. My goal with the work that we're doing at Duquesne, building off the work we've done at FACS, is to create a curriculum that can be adapted in every single medical and nursing school so that the medical professionals, the physicians, the nurse practitioners, the midwives that care for women actually have the tools. But you asked, why is it this knee-jerk reaction? Again, it's the medical education first and foremost, but then it's practice. I mean, the reality is the time that it takes me to spend with a patient to dig into the root causes, to explain how to chart their cycle, to make these treatment adjustments takes time. It's so much easier if a patient comes in, I have painful periods. Okay, here's a prescription for birth control. I can get on to my next patient, right? And so the current medical system does not lend itself well to a restorative reproductive approach. We need time. We need to really dig deep. A lot of women who have cycle-related issues need to work on lifestyle factors like nutrition, sleep, exercise. FACS is going to be hosting a virtual conference this year on October 10th and 11th, and we're looking at these factors. How do we improve nutrition? Why is sleep so important, not only for female infertility, but male fertility as well? What is the role of exercise? It's the story of Goldilocks. Too much isn't good. Too little isn't good. What's that right amount of exercise that women and men need to engage in, again, to optimize their fertility? Nutrition, again, not something really well covered in medicine and not something we necessarily have the time to do in a 15-minute office visit. So we need more funding and more education on addressing not only fertility, but overall health from a more comprehensive, holistic, integrative, and restorative perspective.
Amazing. I'm so excited to hear about what you're doing, and we'll definitely link for people listening so they can check out FACS. Easter is a season to celebrate Jesus Christ's resurrection and go deeper into our faith. That's why I'm a big fan of Hallow app, which is the #1 prayer app in the world. They have a whole series dedicated to helping you go deeper into your faith this Easter season. And they're doing a special on Jacques Philippe's Interior Freedom. This is a spiritual classic that I love and have been benefited by over the years to help us deepen our relationship with God and our freedom as God's sons and daughters. Hallow app also has thousands of prayers, meditations, sleep stories, and even worship music. Some of the content is for kids. A lot of it is for adults. Really, anybody and everyone in the family will find something for them that they can do even on a daily basis on the Hallow app. So during this Easter season, I hope you deepen your prayer life and make use of the amazing tool that Hallow is, the #1 prayer app in the world. And you can try the Hallow app risk-free and completely free for a full 3 months at hallow.com/Lila. That's hallow.com/Lila. So when you say the fifth vital sign, can you explain what is the fifth vital sign and why does it matter for women?
Absolutely. So when I was a resident, we were learning the vital signs. We learned the 4 main vital signs: heart rate, respiratory rate, blood pressure, and temperature. When I was a resident, we learned about pain as the 5th vital sign. I think to myself, what is a vital sign? A vital sign is something that's a sign of life. Well, last I checked, nobody needs pain to be alive. So I kind of rejected the whole concept of pain as the 5th vital sign. But when we talk about the female cycle as a 5th vital sign, in order for a woman to ovulate, her hormones have to function optimally. It's an intricate orchestration. And if the woman's fertility is optimal and she's ovulating, it allows for the continuation of the life of the species. If a woman's hormones are not functioning properly and she's not ovulating, not only does it affect her fertility, but it does affect her overall health. Why? The reproductive hormones, estradiol and progesterone, we think of those about, well, we need that to have a baby. But they're also critical for other aspects of health. Estradiol is critical for heart health. Heart disease is one of the leading causes of death. Estrogen is really important for optimal heart health. How do we know this? When a woman goes through menopause and she's no longer ovulating, her estradiol levels are lower, she has a much higher risk of heart disease or heart attacks. Progesterone, again, we often think of it as a reproductive hormone. It's important in pregnancy. But progesterone is also critical for mental health. It's critical for bone health. The female reproductive hormones are not merely important for pregnancy and having children, but they're critical for overall health. Estradiol is important for heart health. Heart disease is one of the 2 leading causes of death in America. And when a woman goes through menopause, she no longer produces estrogen, her risk of heart disease goes up. Progesterone, while it's important in pregnancy, is known as the pregnancy hormone, is also critically important for women's mental health. We see this in women who suffer from PMS or premenstrual syndrome. It's often due to the fact that their progesterone levels drop precipitously, and it can cause mental health issues such as depression and increased anxiety. Progesterone is also critical for bone health. So the female cycle as a vital sign is not only critical for ovulation and for the survival of the species, but it is a sign of good women's health.
So when you are looking at your own, let's say it's someone's health, right? And you're coming in, a woman comes in, let's just say it's a cystic acne situation, right? So you seeing a very young patient, she's, has gone through puberty, but she has cystic acne. Maybe the periods are not particularly painful, but she's getting treated for that. Again, a decade or two ago, she might have been put on the birth control pill, as I had friends who were put on the birth control pill, especially girls I knew in college, et cetera. What would be the proper way to treat that girl as opposed to just let's get her a birth control prescription?
Yeah, great question. So acne is one of the common reasons, and it can be due to normal hormonal shifts. So one of the first things I like to do is I like to have my patients chart. I have a young patient, 18 years old. She was dealing with cystic acne from the age of 16. We had her start charting, and we could see when she would have those spikes in her acne. So things that we can do to affect it, some things can be as simple as addressing her diet. So there are foods that are very inflammatory, sugar, carbohydrates, processed foods. We really try to get those out of the diet. Having a good skincare routine can also be critically important. Sometimes a lot of these girls, they become very self-conscious. They'll use extra makeup that can actually in turn worsen it. But there's certainly lots of other topical treatments and antibiotics that we can use to often treat it, which again helps because you're treating the root cause. You're not simply shutting down the hormones of her cycle. I like to describe it as, I think the best way to think about the way we treat some women's health problems like acne, for example, you want to do a targeted treatment, right? You want to treat the problem in front of you and not just wash out the whole system. So if you have an ant problem in your kitchen, you want to target killing those ants and not get the fire extinguisher and flood the floor. Yeah, it'll kill the ants, but what damage are you going to do in the process? So the more we can look at the root cause, do a targeted diagnosis and treatment, the better it's going to be for women. Why? Again, hormonal birth control, especially in adolescence, has a whole range of side effects that many women are pushing back on. And I'm not sure if you're familiar with the book called Sweetening the Pill, How Women Are Hooked on Hormonal Birth Control, written by a secular person.
Pioneer work again.
Yeah. Yep. Very outspoken about the harms of birth control and really looks at it from a secular lens, from a woman's rights perspective. Women have the right to have the knowledge about the way their bodies work and to get care that aims to treat the underlying issues.
So my husband and I just had a baby last year. She's 1 now.
Congratulations.
Thank you. But, we had, you're in the hospital. It was a hospital birth. We had nurses in and out. And one nurse came in. I don't think she knew what our preferences were. Well, she clearly didn't. She walks in and she says, so this is number 3, just here to talk to you about your birth control plan. And I, kind of laughed, looked at my husband, rolled our eyes and we're like, our plan is no plan. We don't do birth control for multiple reasons. So anyways, this is so, separate from the whole cystic acne or painful periods. There's just the other push in the medical establishment today, which is if you are, having sex and, whether you're married or not, you should generally speaking make it
be
safe
on birth control
and be on birth control. That's what you should do. And then if you have a baby, even if you just have one baby, you should be on birth control for at least 18 months so you can, even if you want other children, get on the birth. So it is again prescribed like a panacea. And what is almost never part of the conversation is a serious discussion of the harms and separate from a moral question of birth control, separate from that, we can talk about that too. But the potential risks and consequences, the side effects of birth control. You mentioned a little bit earlier, but I would love to hear again, just for our knowledge, because again, the conversation I think culturally gets so partisan, weirdly, around political divides. And it's like, no, what are the actual facts here about the harms of hormonal birth control? Because there's a whole lot of data on this that a lot of people are not aware of. So what would you say are the top 3 or 4 things that women should know about the potential side effects of hormonal birth control?
Yeah. So great question. So at FACS, we do a presentation called The Facts About Fertility Explained. And in it, we walk through from the medical literature, here is a list of all of the side effects. And the slide is full. It affects every single every single health system within the body, not just our reproductive health. So we already talked about increased risk of depression.
But how much? Like, because I think that's one thing. I don't know if we have that information here, but I know that mental health issues are on the rise among women and have been for decades. It's like this strange thing. Why are so many women depressed? Why are so many women anxious? And there's this research that shows, well, birth control pills, which so many women are on too, is not helping your mental health.
It's not. And why is that? Again, we talked about progesterone. The progesterone that your body produces when you ovulate, after you ovulate, crosses the blood-brain barrier and works as an anxiolytic. What does that mean? It helps to calm you. It makes you feel better. You sleep better. When women
your natural
progesterone. When you are on synthetic hormones, progestins, they do not cross the blood-brain barrier. And so this is why we're seeing more mental health issues. We also see an increased risk in blood clots. The funny thing is, Lila, Cosmopolitan did an article on why women are ditching the birth control pill. And they highlighted the stories of women who lost their lives. I have met families who have buried wives, sisters, daughters because of the side effects of birth control.
Wow.
Increased risk of blood clots that can cause heart attack, blood clots to the lung, like a pulmonary embolism. So it's real. Now, the probability is very low. It's less than 1%. But when millions and millions of women are on it, less than 1% is hundreds or thousands of women. Again, one dad was like, I didn't even know. I didn't know she was on birth control. I wish I had known the side effects. I believe as a physician, we need to fully inform our patients about the intention, what the purpose is of the medication, and the side effects so people can make an informed choice. If you have a family history of breast cancer, you may really think twice about taking a medication that could further increase your risk of breast cancer.
EveryLife.com is America's pro-life baby diaper and wipes company. I love EveryLife.com and I use EveryLife diapers and wipes for my little ones because these are a best-in-class product that are clean. There's no harmful dyes or fragrances or phthalates in this product. It is designed to be healthy for your little one and good for your little one's skin. If you go to EveryLife.com/join today, by joining the Changing Lives Club, you not only get 10% off your monthly diaper and wipe subscription, in addition to that, you'll get a free tote bag, and EveryLife.com will donate a box of diapers and wipes to a mother and baby in need. And I'm excited to share, EveryLife.com is now offering training pants for your little one. These are 12-hour leak-proof training pants, pull-ups for that little one that is maybe potty training. You got to check them out. EveryLife also has just come out with their new shampoo and baby wash and lotion package. The product is amazing. I have already started to use it. That's EveryLife.com/join. Use the code Lila.
I often, when I give the Facts About Fertility Explained presentation, we talk about choosing healthy options and informed choice. I'll often use the example of my mom. My mom, God bless her, is a nurse. She spent 40, 50 years as a nurse. So she understands medicine, but she grew up in a time when nurses smoked, and my mom smoked for decades. Despite the increased risk of lung cancer and heart disease, she swore, well, it's going to reduce my risk for dementia. I'm like, really, Mom? She had lung cancer back in 2019 and kept smoking. I'm like, well, you are fully informed. You have, you're making a choice that I wouldn't agree with, but you're making an informed choice. I think women need to understand when it comes to being prescribed birth control, whether it's for pregnancy prevention, whether it's for quote unquote treatment of irregular cycles or painful periods, they need to know what all of their options are. They need to know how this is actually going to treat the underlying condition and what are the potential side effects of the treatment option so they really can make an informed choice. So again, it can cause a whole host. It can disrupt the gut microbiome. It can increase risk of migraines, increased risk of blood clots, increased risk of breast, cervical, and liver cancer. There are so many risks with birth control. Some women, though, feel great on it. They're like, my skin clears up. I feel good. Other women are like, my libido is shot, right? Some people notice, and there's research backing this up, that hormonal birth control can affect who you are attracted to because it changes the pheromones, right?
So crazy.
So it has so many effects.
So you're attracted to a guy and then you get off the birth control pill and you're like,
I don't really
not
like you anymore.
Wow.
But I just want to echo something you had said. You talked about having your third child and the reaction that you had. When I had my third child and I went to see the midwife, she asked me what I was going to use for family planning. And I was like, well, I'm going to use the lactational amenorrhea method. I mean, healthy child spacing.
The lactational amenorrhea method?
Amenorrhea method.
Amenorrhea. What is that? The lactational amenorrhea method?
So for women who have had a baby and the baby is less than 6 months old, if you're nursing or fully nursing and you haven't had a return of your period, the likelihood of getting pregnant is less than 2%.
AKA just be natural and enjoy your baby and nurse them and not worry about
nurse your baby. Yeah. So, and that's the thing. I mean, spacing children is important, but you can do that without birth control. You can do it through using the lactational amenorrhea method. So I said to the midwife, well, right now my baby's 2 months. So we're using the lactational amenorrhea method. But, you know, as he gets older, I'll switch and I'll start using the Billings ovulation method.
Did she even know what that meant? The midwife?
She was like, I know women that get pregnant doing that. Mm-hmm. And I looked at her and I had my sleeping baby on my chest and I was so enraged. And I wanted to say, did you tell that to the woman that you just put the IUD in? Because I've actually delivered a baby with an IUD still implanted. Wow. Because I've seen women get pregnant on the IUD too, right? There is no 100% effective method. But I was so frustrated because this was 2012. I had already started FACS. I'm teaching this. And I thought to myself, if she's saying this to me and I'm feeling offended and like I can't say anything, what must it be like for all these other women who are like, my doctor dismissed me, my doctor was rude.
It's disrespectful.
It's
that is hard. Yes. I mean, I'm not saying they intend the disrespect, but it is disrespectful.
Right. We did a study at FACS a few years ago where we looked at women's experiences talking with their clinicians about their use of fertility awareness-based methods. Fully 1/3 of the women surveyed, we surveyed nearly 1,000 women, so that they had a doctor that laughed at them, mocked them, or made fun of them for using a natural method of family planning. And I'm like, I don't always agree with the choices that my patients make. Like, I didn't agree with the choice my mom made to continue smoking, but I don't mock them or make fun of them. I try and get at what is at the root, right? Again, I want to give grace to my medical colleagues who offer birth control as the primary treatment option because like them, that's how I was trained. And they may not know that there are other options. And this is why we started FACS. We really want to educate our medical colleagues so that they can offer women the full range of options when it comes to addressing family planning or addressing a wide range, not only of reproductive health issues, but hormonal health issues overall.
What you were saying earlier about, there are people that are on, IUDs, long-acting reversible contraceptives, whether it's an IUD or whatever else, an patch or an implant or whatever, or they're on birth control pills and they get pregnant. So, I think about that statistic from the Guttmacher Institute, which is the research arm of Planned Parenthood. And they say of the women who have abortions, so it's a certain cohort, but 50% of them were using a contraceptive the month that they got pregnant.
Right.
Now, of course, there's imperfection in the use. So it's not like they necessarily were using them perfectly, but they were using them. And the reality is, like you're saying, there's a failure rate. So this kind of, this dismissing of, fertility awareness-based methods as they're somehow lesser.
Yeah.
They're natural. They work within the order of the body and they don't have all these harmful side effects, which is we are so misled about the side effects of hormonal contraceptives.
Right. And the beautiful thing about natural methods is they really empower women by educating them about the way their bodies work. What I think shocks a lot of people, and we just launched another elective this block, and one of the students said the thing she found most surprising was that women are actually only fertile. They're only capable of conceiving for less than 1 week out of their cycle, based on their normal physiology. When women learn to chart with fertility awareness-based methods, they learn to observe one of the key signs of fertility, whether it's cervical mucus or fluid secretions, basal body temperature, urinary hormones, and they use this information to identify that period of time when they are able to get pregnant. Again, physiologically, women are almost always infertile. They can only get pregnant 3 to 6 days out of their cycle. And when they learn to chart with a natural method, they identify that window of fertility. And then together, a couple can modify their behavior depending on their family planning goals. Another thing I teach my students is that natural or fertility awareness-based methods of family planning are true methods of family planning because people can use them to plan to prevent pregnancy, or they can use these methods to plan to try to achieve a pregnancy.
Such a good point.
Again, just modifying their behavior. So women find this incredibly empowering. It also helps them understand what's happening with their cycle. They often will learn to be able to identify and predict when they're going to get their period. When I teach my teenage patients about charting their cycle, that's the thing they love most. It's like, oh, now I know when I'm going to get my period and I don't have to worry about it like, coming unexpectedly when I wasn't planning on it. So natural or fertility awareness-based methods really educate and empower women. And we want to be able to do that because sometimes it can solve a seemingly challenging problem in a very easy way. We talked about infertility being so common. Now it's up to like 1 in 5 or 1 in 6 couples. When I was working in inner city DC at a federally qualified health center, taking care of a mostly Medicaid population, I had a couple come in because they couldn't get pregnant. They've been trying for over a year, so technically met the definition for infertility. She was 27. I mean, like the ideal age to have a baby. Her husband was 30. She thought that there was something wrong with her because her husband had a child from a previous relationship. And she described for me this recurrent infection that she would get month after month. This discharge that whenever she would get it, she would not have sex with her husband because she didn't want to give him whatever it was that she had. When I heard that, I was like, can you describe a little bit more this discharge? She was like, yeah, usually starts a few days after my period. Sometimes it just starts as cloudy or creamy, but then it gets like clear and there's a lot of mucus. And so whenever I have this, I just don't have sex with him because I don't want to give him whatever this is. And I was
so sad.
Oh my goodness. What you are describing is your normal fertile cervical mucus when you are getting ready to ovulate, when you are entering into your fertile window. So they had proven very successfully how effective natural methods can be for preventing pregnancy because they didn't know.
She must have been so relieved.
She was so relieved. I mean, I did a
That
workup.
is a good thing. That's called your fertility. Wow.
And I was like, everything was negative. They were pregnant within 2 months. She was like, you're a miracle worker. I'm like, no, I just taught you the way your body works. And so many couples need this information.
Basic information.
If I had been any other doctor, she'd been trying for a year, I'd been like, well, let me send you to a specialist and put her down this path unnecessarily.
So you ask the extra question, right? That's half the battle is actually taking the time to get to know what is going on with this patient, which you were saying, there's this like in and out in modern medicine, like in and out, you have a few minutes, make a prescription, set them on their way. And that doesn't really do justice to the patient.
Yeah. Exactly.
I want to get into some of these fertility awareness methods, which are so interesting, and there's several of them. So I want to get your take on that. But before that, two more quick questions on birth control. There is a data. It seems not just data. It's actually my understanding. It's in some birth control inserts. But can birth control, hormonal birth control, operate as an abortifacient?
Mm-hmm. Great question. And let me just start with this. I never use the word abortifacient because it's not technically accurate. I think the more medically accurate term is embryocidal. Does it kill the embryo? And that's a great question. And
tell me the distinction, because abortifacient is something designed to cause an abortion, but you're saying you like the word embryocidal.
Because the birth control pill, it's not designed to cause an abortion, but it can result in the death of the embryo.
Got it.
And the term abortion is used more broadly, like spontaneous abortion refers to a miscarriage, right? And I think just in our culture, when we use the word abortion or abortifacient, it puts up, people block you and they don't want to have a conversation. So from a medical professional perspective, I want to be as medically accurate as possible. And so with hormonal birth control and with IUDs, for example, in particular copper IUDs, they work by creating an inflammatory environment to prevent the implantation of a newly formed human embryo. And words matter, Lila. So like using the word embryocidal, using the word pregnancy. I don't know if you're aware, but in the 1960s, the term pregnancy was redefined by ACOG to begin to refer to pregnancy beginning at implantation of the embryo. Well, you can define pregnancy as beginning at implantation, but the science shows that new human life begins at the moment of fertilization,
and that's
which
implantation in the uterus. So when the baby actually implants, but this is several days after fertilization.
Exactly. So fertilization, when the sperm fertilizes the egg and forms a human zygote, that happens in the fallopian tube. And it takes about 5 to 9 days for that human zygote, which is rapidly dividing, forming a blastocyst, a morula, an embryo, to then implant at about 1 week post-fertilization. So that embryo is just about a week old. Okay. With some forms of birth control, like the IUD, it can create such an inflammatory environment in the uterus that there is no place for the embryo to implant. With common forms of combination hormonal birth control pills, oftentimes women will be prescribed hormonal birth control for heavy bleeding. Why? Well, it will help to thin the uterine lining. Even women who have normal cycles who take hormonal birth control will notice that their periods are much lighter. Why is that? The woman does not build up a thick uterine lining. If a woman does not build up a thick enough uterine lining, that newly formed embryo may not be able to implant. And as a result, it causes the loss of the life of that embryo at its earliest stages. How often does this happen? We don't know for certain, but there is a research showing that women who take hormonal birth control ovulate about 30% of the time. And this is based on research by my 30%. Colleague, Dr. Buskmiller. Yes. So 30% of the time, women who are taking hormonal birth control will ovulate. Well, the failure rate for hormonal birth control is 10%. So what's that other 20%? It is likely that some of those is the early loss of the embryo within that first week before implantation even occurs. Again, for some people, that may not be a concern. They may not have a moral issue with it, but I think every woman deserves to be given full informed consent. So she understands that by taking hormonal birth control, that may thin the uterine lining and work by preventing implantation of the embryo. It doesn't always work by suppressing ovulation. It's just important to note. And the drug inserts on birth control show that it works by suppressing implantation, thickening the cervical mucus to prevent sperm penetration, and thinning the uterine lining to prevent implantation of the embryo at its earliest stages.
I've talked to a lot of women over the years about these things, of course, as I know you have, but I've noticed that many women who are very passionately pro-life, they're maybe not fully aligned on the birth control issue maybe yet, meaning they weren't really given education about the harms of birth control. They don't necessarily have this vision of working with the body and God's plan. So that's not like fully there yet, but they're kind of, wanting to make good decisions, especially for life. They will say, well, is there a birth control method? They'll ask that cannot operate as a feticide.
As an embryocidal.
Embryocidal. You're using the word embryo because, of course, they're an embryo, an embryocidal. Did you coin that term, by the way, Dr. Duane?
I don't think I coined the term, but I've been using it for a decade.
Okay,
so.
I'm going to give you the credit for that one. That's a good one. So the embryo, but the way that birth control can operate as an embryocidal, are there birth control methods that do not operate as an embryocidal?
I mean, certainly barrier methods like condoms, right?
Like pills or patches or implants, they all have that potential risk.
They could potentially.
Yeah. So then another question, you are listing some of the other harms of hormonal birth control. And you were talking about women who were maybe on the pill for years and then finally came off of it. I've talked to many women over the years who were on the pill for years, went off of it usually in their 30s, sometimes late 20s, and then they want to have a baby. And then they struggle. Is there a link between birth control and being on birth control for years and potential infertility later on?
Likely, because oftentimes, again, hormonal birth control is being prescribed for painful periods or irregular cycles. And as we discussed, the most common cause of painful periods is endometriosis, which is one of the two leading causes of infertility. When women are prescribed hormonal birth control for irregular cycles, one of the most common causes of irregular cycles is polycystic ovarian syndrome. Again, one of the two leading causes of infertility in women. And when women are on hormonal birth control, you're not treating those underlying conditions, right? So you have a disease that's progressing for 20 years, you go off the pill, and now you've delayed the time for adequate treatment. And as women age, we often think of fertility decreasing at 40 or 35. A woman's fertility actually begins to drop at 32, right? And if you have a woman that goes off the pill at 35 and she has endometriosis, it may take time to treat that, or polycystic ovarian syndrome. So you're increasing the risk of infertility by virtue of the fact that now they're older, and age itself is a risk factor. One other important thing to note, we talked a little bit about cervical fluid as one of the key signs. I talked about that patient who noticed the cervical fluid and thought it was a problem. What people don't realize is how critical cervical fluid is for fertilization. In one of our facts presentations, we talk about there are 3 things that you need to make a baby. You need an egg, you need a sperm, and you need fertile cervical fluid. Why is that? I like to say, and I coined this term, cervical fluid is the elixir of life. Why? In the absence of fertile cervical fluid, sperm can only survive in the woman's reproductive tract for 6 to 12 hours.
Wow.
the woman's reproductive tract is a hostile environment for sperm, but in the presence of fertile cervical fluid, sperm can survive for up to 5 days, which is amazing. And that cervical fluid is produced in glandular cells of the cervix, and it produces different types. What's important to note is that there's a researcher by the name of Dr. Eric Odeblad from Europe. He spent 50 years studying the cervix. He was an OBGYN and a PhD researcher. And what he discovered is that in women who are pregnant, during pregnancy, it upregulates those glandular cells. So when a woman has a baby, it's easier for her to have a baby in the future because she has more of those glandular cells to produce that fertile cervical fluid. What he also discovered is that for every year a woman is on hormonal birth control, it actually ages the cervix.
Wow.
So if a girl is put on the birth control pill at 15 and goes off the pill at 30, she doesn't have the cervix of a 30-year-old. She has the cervix of a 45-year-old. And she may not be making as much of that fertile cervical fluid, again, that elixir of life, critical for sperm survival, as she would have had she not been on birth control for 15 years. Now, does this directly correlate to an increased risk of infertility? The answer is, I don't know. We don't have the research.
It sounds pretty, again, like you're saying.
It's a plausible hypothesis, but
and women deserve to know it.
They deserve to know that.
Most have no idea of what you just shared, which is mind-blowing and incredibly important.
And we need more funding for research in this field, in the realm of restorative reproductive medicine, so that we have more answers for women, so we can help them address risk factors for infertility, miscarriage, how to treat a wide range of women's health conditions in a way that really seeks to restore health.
I'm so grateful for your work in that area, because you're obviously doing this through a nonprofit, through FACS, which I recommend everybody check out. It'll be in the link in the description here. But I know that even the White House, has indicated, President Trump's administration, we want more babies. Babies are good. We have a declining population. The birth rate is below replacement rate. And so let's fund IVF. And it's like, okay, what about, restorative reproductive medicine? What about everything that you're talking about? I just don't think enough. There's no big lobby. The pharmaceutical companies, the IVF industry, big fertility, big lobby, lots of money. What you're doing is, let's actually care for the patient.
Yes.
And so there's not this $1 billion pharmaceutical company, backing what you're trying to promote, but it's actually the solution to so many of the problems we're discussing. So anyways, it's so important. Can
I just touch on that? Because I think you're right. I mean, the good news is there are a lot of us. We talked about the different methods of natural family planning, Billings and Creighton, Marquette. So many of us are working together to get information to the government so that they can see there is an alternative, especially when it comes to infertility. I think an important thing to note is infertility is not a disease. It's actually a symptom of other underlying diseases. And this is the fundamental flaw with IVF. IVF treats infertility as the disease. If we can make a baby in a test tube, we've solved the problem. Well, if you can make an embryo in a test tube and implant it back into the woman, IVF should have a 100% success rate. It doesn't. The success of IVF is anywhere from 3 to 30%. Like the patient that I shared who, went through IVF, she has 1 child and lost 2. So a 33% success rate. So far working with me in 4 months, she has a 100% success rate using restorative reproductive medicine. Why? We recognize that infertility is a symptom of other underlying diseases, and we work to get at the root cause. Another issue is miscarriage. I have a patient right now. She became my patient because she had 3 miscarriages, and her doctor was like, well, you need to do IVF. And she's like, but I'm not having trouble getting pregnant. And we're like, well, we need to genetically screen the embryos and remove the ones that might not survive. AKA
destroy them, by the way.
Exactly. And so she started working with me. I said, well, we need to look at what are those underlying modifiable risk factors for miscarriage that we can address and prevent. And Lila, there are some really simple, easy things we can identify and treat to prevent miscarriage. So that patient I shared with you, she's now 4 months pregnant with me because we identified thyroid disease as a condition in her that once we started treating, she's now 4 months along in this pregnancy. So I don't know if I shared with you, but in 2020, I moved my family from Washington, D.C. to Utah to do a 2-year research fellowship. And my focus was on miscarriage and identifying those risk factors. Why? Just like infertility is contributing to the dearth in children, miscarriage, the inability to carry a pregnancy to term, is also contributing. And miscarriage is the silent problem that women don't talk about, but it is so common. I mean, the statistics suggest there's close to 1 million miscarriages a year that women are losing their babies. What are we doing to try to address that? At Facts and through our work, we're doing so much to address that issue.
What's crazy to me is how little we know about why miscarriages happen.
Mm-hmm.
I think there's so much, there's so few answers for women. And I know my husband and I, we had a miscarriage between our first and our second, but we were really blessed that that's just been one. I know families that they've had multiple, 6, 7, 8, 9 miscarriages. And when they go to their physician, there's not really an answer for why this happens, except it's happening, right? And sometimes they might be turned towards things like IVF, even as some sort of a solution. Your research is so fascinating in this area because, again, it's pioneer work. Not surprised, it's Dr. Marguerite Duane. Tell me, what are you seeing in this new space of actually finally studying miscarriage? Why are miscarriages happening in your view? And how do we actually solve and heal underlying conditions so that there are less miscarriages?
Yeah, great question. And again, I think, unfortunately, the way we're trained in medicine is that miscarriage is common. It happens. We're taught not to even look for the underlying causes until a woman had 3 miscarriages, right? And as a mother of 3, I ask you, would you stand with losing 1, 2, or 3 children before you're like, let me figure out what's going on? No. And yet this is how we are trained. What I have discovered through my research is that what we learn is that the most common cause of miscarriage is a genetic anomaly. And the reality is if there's a genetic abnormality, that's nothing we can do anything about. It happens about 50% of the time with the first miscarriage. But in women who experience...
How do we know that, by the way?
So it's actually based on relatively old data where they would look at the remains of the embryo or the fetus and do genetic testing to see if there were genetic abnormalities.
And when you say genetic abnormality, it's something so severe that the baby has that they can't continue to grow. They die.
Exactly.
They pass away naturally because genetically they're not able to continue to develop.
Exactly. But in women who have recurrent miscarriage, who have lost 2, 3, 4 or more babies, the genetic reason is less than 5%. More often it's due to an endocrine issue, an anatomic issue, a lifestyle issue, things that we can address.
In the mother, not the baby.
And in the father.
Wow.
And in the father. And that's really important to know. So I have a patient currently, she, was blessed with 3 healthy pregnancies and had 3 children. And after her 3rd child developed postpartum thyroiditis, was treating her condition, but had miscarriage after miscarriage after miscarriage. She came to me with her 9th pregnancy. So she had 3 miscarriages, and now this was her 9th pregnancy. And we identified some factors that we started treating. She was about 6 or 7 weeks. Unfortunately, she lost that baby. And I was like, well, let's make sure once you've kind of gone through the mourning and recovery process, we address some of these underlying factors. But for now, I want you to continue to follow this treatment plan that I had laid out for her. So she followed that treatment plan. By the time she came back to see me, she was pregnant again. She's now 36 weeks pregnant at the age of 42.
Wow.
And she's like, the only thing I did different was the dietary plan you recommended and the medication that I had recommended for her. So there's so much that we can do.
Do you mind me asking, what was her?
Yeah.
So you recommended, you had a treatment plan. She had 3 miscarriages. She had
5 miscarriages.
5 miscarriages. Yeah. You see her, you give her a plan. It's both nutrition and a medication. And then she's now 36 weeks pregnant. She's obviously has not miscarried and will not miscarry.
No. She's due the end of April, so we're waiting excitedly.
If the baby comes now, this baby is going to be, okay, provided there's not some horrible thing that happens in the birth. But again, it's a success story is what I'm saying.
And I had patients who have 8, 9, 10 miscarriages. So it depends, and it's going to vary. So I had one woman who had 8 miscarriages, and she had received progesterone. Progesterone can often be a necessary treatment to support a pregnancy and to prevent miscarriage. There's actually solid research that's come out of England that shows in women who have a threatened miscarriage, that is bleeding in early pregnancy or recurrent miscarriage, progesterone beginning as soon as we have a positive pregnancy test can significantly reduce the risk of miscarriage, right? My colleague,
that's, by the way, really, I just even a girl, not a personal friend of mine, but a friend of a friend, was fearful she was starting to miscarry, has had a previous miscarriage, was just trying to get a progesterone prescription. having so much trouble because she's being poo-pooed. Like she's being told by whoever she was saying, oh, this isn't going to do anything. Miscarriage is natural. You've only had one. It's not a big deal. And she's like trying to save the life of this baby, potentially save the life of this baby.
Right. And the reality is progesterone we're giving is the bioidentical progesterone. It's the hormone that the woman's body is producing. So there's really no risks associated with it. I mean, there are side effects, and you always have to inform patients of side effects, like it can increase fatigue and other things, but it's pretty safe. And so if it's like, I'm willing to put up with those side effects to potentially save the life of my child, it's very, very important. Another treatment that we often look at is estradiol. So my colleague, Dr. Phil Boyle from Ireland, he did research looking at pregnant women, and he found in women who have normal hormone levels, including normal progesterone levels, if their estradiol levels were low, their risk of miscarriage was 45%. Now, the typical rates of miscarriage are 15 to 20%. So 45% is 3 times the normal. In these women, when we give them DHEA, which is a hormone that the body uses as a building block to make estradiol, their miscarriage rate drops to 17%.
Wow.
So these are simple, straightforward treatments that I, as a family doctor, can employ to help save the lives of these children. So the other treatment that Dr. Boyle often recommends, and this is what I'd used in the case of this one woman with an autoimmune thyroid condition, is a medication called low-dose naltrexone. If your listeners Google naltrexone, just to put it out there, it's commonly used for people with opioid addiction, but at a low dose, it actually helps to balance the immune system. I had another patient who had 3 miscarriages last year, had a history of Crohn's disease. There's a good randomized control trial that shows low-dose naltrexone significantly improves Crohn's disease. We started her on the low-dose naltrexone at the beginning of her 4th pregnancy. She had a beautiful baby boy in November. So again, she was on her way to see an IVF doctor when she got my name and my number, and we were able to help her. So I just want to give hope, and I just want to take a minute and for all of your listeners who've experienced miscarriage, and I know it is so common, just I see you and I hear you, and my heart goes out to you for your loss. I recognize your doctors may not know what to do, but please have faith that there is hope. And at FACS, we are working to train as many doctors as we can to recognize miscarriage for what it is, a very common problem. As we said before, miscarriage is not tracked as a cause of death in the United States. But if we did track it as a cause of death, again, there's about 500,000 to 1 million miscarriages a year. It would be the 3rd leading cause of death in the United States of America after heart disease and cancer. Look at everything we do to identify and prevent heart disease and prevent cancer. We need to look at miscarriage in the same light. I think, unfortunately, because of issues surrounding women's health, you know this, they're very political. People don't want to talk about progesterone can prevent a miscarriage because progesterone can also help in women who have, perhaps chosen to do the abortion pill. And so it gets into political worlds. At FACS, though, we're really focused on the science. I want women and their doctors to have up-to-date evidence-based information. So for my medical colleagues curious about progesterone and miscarriage, I refer them to the work of Dr. Kumarasamy, who's published multiple reviews on this topic.
It's so amazing. What would you say needs to happen in the research space for us to properly understand? I mean, I was particularly shocked by what you're saying, how 50% roughly potentially of those women who have their first miscarriage, it's likely genetic. Mm-hmm. But once you're having multiple miscarriages, that number shrinks down into the single percentage points. Mm-hmm. So we're talking about other things that could be treated potentially.
Yes, absolutely.
Are you hopeful with what you're seeing in the miscarriage treatment space?
I absolutely am. At least what I'm seeing in my own patients. I'm excited to have a student working with me this summer just to look at the data from my own patients, because we have seen such a huge benefit. But there is more need for research. We talked about low-dose naltrexone. Naltrexone is a generic medication. So no pharmaceutical company is going to make a ton of money off of doing research on naltrexone. So you think
that's why there's a lack of education about its availability?
We need more research on the role of low-dose naltrexone in addressing things like endometriosis, recurrent miscarriage, etc. So at Duquesne, where I'm now the director of the Center for Fertility Awareness, Education, and Research, this is what we want to do. We want to look at, we hope to develop treatment protocols for identifying and addressing things like recurrent miscarriage, male infertility, polycystic ovarian syndrome. We need more funding to be able to do this research. For your listeners, I did a podcast recently with Lisa Henderson Jack from Fertility Friday, where I specifically dove deep on the need for more research in the restorative reproductive medicine space. And fortunately, there are people like my mentor at Utah, Dr. Joe Stanford, who is pioneering research in this area with the STORM study, surveillance, treatments, and outcomes for restorative reproductive medicine. So there is hope on the horizon, and it's exciting to be able to collaborate with colleagues across the methods, across the disciplines, to try to bring this to the patients, but also to try to bring it to the government so that this administration will actually recognize and support real solutions to addressing infertility and miscarriage, to really address the fertility crisis we're seeing in America.
It's truly the most loving work. I mean, it just makes me so happy. My heart's so happy. I'm thinking about all the women. I mean, it makes me want to cry, just who are just struggling and they are hoping to have babies. They try, there's miscarriage, repeat miscarriage. It's so devastating. And the fact that there is a future, you know, there is, if more research is done, if they have more of an opportunity to meet with a doctor, like the ones that you work with, there could be such a bright, a happy ending to those stories that are being written, instead of what they usually get, which is we can't solve miscarriage, or just go do IVF, you know, or even get on the birth control pill. You have these problems, you know, probably shouldn't be a parent anyways. I don't know. They're usually not saying that now. They're just saying, send you to the IVF clinic.
Right. And to my medical colleagues, like, again, I realize we don't learn about this. And so, you know, FACS really focused on medical students to begin with, but now we have this extensive online continuing medical education course.
Amazing.
There's 13 parts. You know, I just spoke to an OBGYN who's been practicing for 20 years. He heard me give a presentation on miscarriage. He's like, how do I do what you do? Like, where can I learn more? I'm like, let's start with part A and B of our CME course. You'll learn about the different methods. You'll learn about identifying, you know, causes of miscarriage, how to treat it. So to my medical colleagues, I would refer them to the factsaboutfertility.org website to learn about our continuing medical education courses, our conferences. Like I said, our virtual conference will be October 10th and 11th this year. We just did a conference in Pittsburgh in March, and it was phenomenal. We had over 150 people from all over the United States looking at treating infertility from a restorative reproductive perspective, addressing nutrition, providing body literacy education for all women. There's so much that we can do, but we need to really work together to expand training opportunities, fund research, and collaborate as medical colleagues so that we can provide the highest quality care to our patients through an integrative and restorative lens.
And when you say nutrition, you've mentioned that several times. Is there sort of just high level, maybe a few core tenets of nutrition that you recommend across the board to women if they want to ensure that their fertility health is maximized?
Yeah.
What would those things be?
So one of the most common causes of both ovulatory dysfunction and spermatogenic dysfunction is a condition called insulin resistance, which is really the precursor to prediabetes and diabetes. To address insulin resistance, it is so important to ensure your weight is optimal and to minimize blood sugar and insulin spikes. So what I tell my patients is consider your vegetable your appetizer. Start every meal with a vegetable. Then focus on protein and consider carbs your dessert. Why? If you begin with a vegetable and a protein, that's going to slow the body's absorption of blood sugar and minimize the insulin spikes. That's important because if your insulin is really high, that can affect your body's ability to ovulate, and it can affect male sperm production. Inflammatory foods, processed foods, excess carbohydrates, sugar, those are all honestly terrible. Again, my colleague, Dr. Patrick Young, who's one of the leading endometriosis surgeons in the country, he has a practice, Restore Endo. He has got a great dietary handbook that I give to all of my patients, an anti-inflammatory diet to help reduce the risk of endometriosis. So that's typically where I start. And then again, incorporating exercise. If you can walk for 15 or 20 minutes within 30 to 60 minutes of a meal, that's also going to improve your body's responsiveness to insulin and lower the risk of insulin resistance. So unfortunately, in medicine, we don't learn a ton about nutrition. So this is where I really rely on my nutritionist colleagues, and we're thrilled to have a registered nutritionist who's going to be speaking at our virtual conference on October 11th to address this very topic.
One thing I'd love to do, and I've been like, excited, like I want to hear let's do, I don't know if it's a 30-second project. I know there's so much under each of these, but I'd love to hear, just when it comes to fertility awareness-based methods, I'd love to hear your kind of high level on Marquette, Creighton, Billings. I think there's at least one or two more. just give us the very high level, back of the napkin. What are these methods? I know people listening are like, I'm in on this. If I'm not already doing, fertility awareness-based methods, I want to know. And by the way, my full disclosure, my mother-in-law was a Teen Star director at one point. And she was, we were talking about it. She said, she has 5 daughters, educating her daughters in their teen years about their fertility, even before they started their periods. Like every girl deserves this education.
Exactly.
Even before their period starts.
Exactly.
Almost none of them are getting it.
Yes.
Like sex ed in the schools today is all about like condoms. I mean, It's just totally messed up. Anyways, what are these fertility awareness-based methods? Give us the high level and the difference between them.
Sure. Yeah. But I agree wholeheartedly. We need to start teaching girls when they're young. At FACS, we have a presentation called Know Your Body, which provides that introduction into the female cycle and how it works. And then again, our Facts About Fertility Explained goes into the different signs women can observe and the methods. So we can break these methods down into categories. You have cervical mucus or fluid only methods. These include the Billings ovulation method, the Creighton model, and the 2-day method. With these methods, women learn to pay attention to the sensation that they feel in the genital area, and they learn to observe cervical fluid secretions. And with Billings, they'll just write down their descriptions in their own words. With Creighton, they'll use what we call a vaginal discharge recording system to write down a more detailed description of their observations. Fertile cervical fluid is produced under the influence of estradiol, and it will cause this production of like clear, stretchy, slippery mucus. It's just like raw egg white. If you've ever cracked open an egg, that's what it looks like. Then under the influence of progesterone, it changes the cervical mucus, and women will often notice a drying up, or they'll notice a mucus that's very thick or cloudy, but distinctly different from the fertile mucus. With a cervical mucus only method like Billings and Creighton, women can learn to identify the beginning and the end of their fertile window. Then you have symptothermal methods. With these methods, women learn to observe the symptom of cervical fluid secretions and their basal body temperature. They take their temperature at the same time every morning, and with the rise in progesterone after ovulation, you'll get a rise in basal body temperature to confirm the closing of that fertile window. So women will use observations of cervical fluid to identify the opening of their fertile window and the rise in basal body temperature to confirm the closing of their fertile window. This method is taught throughout the United States through organizations like SymptoPro, Couple to Couple League, Sensiplan, etc. Many of the apps out there incorporate symptothermal, but I do caution your listeners when it comes to apps. I like to tell women, you are smart. You're smarter than your smartphone. Don't let your app tell you when you're fertile or not. Learn to make these observations and interpret them. And I always recommend women working with a trained instructor.
Would that be a mix then of methods, basically? You're saying you can use multiple methods to get more clarity, multiple data points ultimately.
But more data points doesn't mean more clarity. Okay. So some women do like the cross-check method. If you want to check mucus and temperature, that's great. But learn from a trained SymptoPro instructor or a couple-to-couple instructor. And then if you want to use an app to facilitate tracking, that's fine. But learn how to make the observations and interpret them from a trained instructor. Then you have what we refer to as symptohormonal methods. Most commonly is the Marguerite model. This involves tracking cervical mucus plus urinary hormone measurements. Marguerite uses the Clear Blue fertility monitor that can detect estradiol metabolites and luteinizing hormone, which are 2 of the key hormones. There are now a number of newer monitors on the market that have not been proven yet from an effectiveness perspective for pregnancy prevention, but there are ongoing studies to look at whether or not these other monitors may be helpful. And of course, I already mentioned it. My all-time favorite method was the lactational amenorrhea method because it was the easiest. All I needed to do was nurse my baby, and loved that method.
And I've talked to women who they're nursing their babies and they're like, I'd like to get pregnant again. I'm like, you're nursing your baby.
Yes.
Or at least maybe too much. You're nursing their baby.
Yeah. And that gets into one of the hormonal issues that we see can cause infertility. Like when a woman is nursing, her prolactin levels are high, right? Prolactation. When your prolactin levels are high, it suppresses ovulation. So why? Well, if you're nursing a baby, your body's too busy growing this baby on the outside to try and grow a baby on the inside. But I oftentimes will see women struggling with infertility who don't have a nursing baby whose prolactin levels are high.
Wow,
and that will affect ovulation.
How do you treat that?
It's very simple with medication.
Wow.
So again, doctors just need to look at this. Wow. And there are protocols like FEM, the Fertility Education and Medical Management, NAPRO Technology, and Neofertility that all have medical management protocols for doctors to be trained in to then work at making that diagnosis and treat these underlying hormonal or anatomical issues that can contribute to infertility.
It's amazing, Dr. Duane. You're doing God's work. I mean, seriously, it is revolutionary. You are the pioneer. How can people find facts and find your work?
I mean, visit us at factsaboutfertility.org. I will say I would not be able to do all of this incredible work without the amazing team that we have at Facts. And over the years, we've had so many volunteers and so many supporters that have donated to support our work. My sister, remember I mentioned I sat next to my 9-year-old sister and she and I were like jockey for position. She went on to become a trauma critical care surgeon.
Wow.
And although she doesn't do the work that I'm doing, she has been our number one supporter financially, emotionally, our biggest cheerleader. And of course, my own family. I mean, my husband and my 4 children. My daughter said to me once when I was like, you have to go, Mommy, because you have to help all of these women to have babies like you have. I'm like, you're so sweet. Like, yes,
Beautiful.
I feel so blessed to have 4 incredible children. And I want every woman, every couple to experience the gift of parenthood that my husband and I have been able to experience. Again, I would not be able to do all of this work without my incredible family, my husband, our children, my siblings, and again, the entire team at Facts About Fertility. So visit our website, factsaboutfertility.org. You can email us at info@factsaboutfertility.org. If you are trained in these methods or a clinician, we have a physician, clinician, and educator directory. We're trying to build it to increase access so more women can have access to this care.
That's so beautiful. Thank you so much, Dr. Duane.
You're
Seriously,
welcome.
it's such a gift to have you on. You are amazing. And
Thank you.
everybody check out Facts. If you don't already get supported by Facts and the information, make sure you donate if you can, because Facts is amazing and it's doing pioneering work.
Thank you so
much, Dr. Duane.
My pleasure.
Thanks so much for watching this episode of The Lila Rose Show. Make sure you check out Dr. Duane's incredible work. It is linked in the description of this episode. Check out Facts, check out her work. It's amazing. Share it with other people. And don't forget, we're over at rosereport.supercast.com and we're doing some extra bonus content with Dr. Duane. You can check it out at rosereport.supercast.com. We'll see you guys next time. And a huge thank you to EWTN, Eternal Word Television Network, which is the largest religious broadcaster in the world. You can get access to Lila Rose Show episodes 24 hours in advance at EWTN.com/on-demand. And a big thank you to EWTN and their incredible mission to bring souls to Jesus.